Next, we will go on to a very advanced topic, that is intraoperative abrometry pros and cons by Professor Jagat Ram. He needs no introduction, but right now he is working with the Grewal Eye Institute. He was Professor and Dean of PGI Chandigarh, and there they had the Intraop abrometry, and then he has had some experience with the Intraop abrometry, and he'll be sharing it with us.
Thank you, Dr. Shri Ganesh, for giving me this opportunity. I will be speaking on intraoperative barometry pro and cons. Real-time analysis allow this adjustment of IOL power intraoperatively, and we use the infrared light and interferometry. Analysis of the data from the central 4 millimeter calculate the IOL power. What are the benefit? What are the pros? It can be effectively used in myopia, post-refractive surgery, placement of toric IOL, even axis, whether any further rotation required or not, and in many of the other situation, even in such as radial keratotomy and other patients. But the problems are that this is not suitable for short eyes, where intraocular pressure is low. If there is central corneal opacity, even lid speculum will also produce some uh, problem, and if patient is not fixating. So I will be showing some of the video. This is normal cataract, 60-year-old, where we planned that we will place multifocal toric IOL. This video is about 5-6-year-old. Once we remove the cortex and uh, then we fill the anterior chamber and capsular bag with viscoelastic and do aura. And this is the power. But already we have done the power with IOL master and other modalities, but we match whether it is the same or it differ. But it is very accurate. So we have done even comparison of this aura with the other modalities. This is another small video. This is in a pediatric cataract. It is a classical zonular cataract. Roughly we have already marked the horizontal axis. After removal of the cortex, we fill the capsular bag and anterior chamber with viscoelastic. Pressure should not be low, but then we adjust it and see that what IOL power comes. Because child is under general anesthesia, so we have to make fixation much more accurate, and it gives IOL power. But in children, we have to adjust the IOL power underestimation. That is what you have to do. This is here we are using Callisto. As Callisto is also found to be accurate, and then we see whether any rotation of the IOL is required or not. It says NRR, means no further rotation required. And then comes in some of the other condition where there is a radial keratotomy. Because when we started doing it, it was a question of comparing it with the other modalities. Incisions are adjusted between the radial incisions. Main incision and side port incisions, depending upon where there is a more space or where it is required. And then performing a phacoemulsification in the eye. Again, this procedure remains same for any type of the eyes, but particularly in radial keratotomy, particularly if there is a central haze, there is a corneal opacity in the center. In this patient, it is a clear visual axis, so no issue, no problem found. But otherwise, it may not even measure it. Fixation is extremely important, and here it shows 31 diopter power. So more than 30 diopter comes in only few of the IOLs. These are the RK patient who has most of the time post-operative residual hypermetropia. So that has to be corrected, or it appears to be little more accurate compared to other formula. So in conclusion, intraoperative aberrometry is a newer technological advancement which is useful tool in patients with extreme of the keratometry or many of the post-operative situations. Thank you very much.
Thank you so much, sir, for the very elaborate talk. Up next, we have none other than Dr. Sri Ganesh, who's going to talk about the toric IOL calculations and perfecting the outcomes. While sir is getting set up, sir, a quick question to you, sir. While using the Aura, I mean, I know it's an expensive device, but that apart, how do you ensure that the amount of viscoelastic which is filled in the eye is comparable to the physiological IOP and we don't overinflate and underestimate the IOL power?
One of the, if it is a low pressure, it will not even detect it. So yeah, it has to be adequately filled, and then if it comes, you have to adjust, uh, and if it comes still low, you can inject more. So gradually you have to inject, but if it is over is also not more, it is also not fine. So it is a note, I think. First we were also trying it, that how much to fill, but uh, it comes with the experience that it should not be low, it should not be very high, it should be just appropriate.
Another question I wanted to ask you, sir, how do you account for the effect of the lid speculum?
Yeah, that is very right. I think there should be no pressure. There should be no pressure. It should not be very tightly placed, or type of the speculum also matters. So that also gives false. That will give, I think, some problem in estimating the power. That I said in the problems associated, that if there should be no undue pressure on the globe.